we're made up of lots of different parts, things like our ethnicities, our genders, income, living with whether we live with a disability, the kind of jobs we have, where we live. And these parts don't exist separately to us. They're not separate entities. They overlap and they influence each other. And that's what I mean when I refer to the term intersectionality. So this is what really we're all coming here today to talk about. It's this concept of all of these overlapping factors that influence our experiences of health and healthcare, and especially access and involvement in research. So in today's session, we're going to explore this idea a little bit more and think about how it affects designing research to be more inclusive. So if we only look at one factor at a time, we do risk missing the bigger picture and missing potentially what really needs to be taken into account if we want research to be designed in a way that truly makes a difference. So I've given you a little bit of background on this idea of intersectionality and what it means in research. And now I'm going to walk you through a short example, which gives you an idea again of what this concept means in practice and why it really matters in research. So let me introduce you to Mariam. So Mariam is a 60-year-old woman. She lives in a busy UK city, but not in a well-connected part of it. She doesn't drive, and the local bus routes are infrequent and expensive for her. She's from a minority ethnic background, and she speaks only very basic English, as it's not her first language. At home, Mariam is also the main caregiver for her 2-year-old grandson, and she lives on a low income and was recently diagnosed with type 2 diabetes. So over the years, Mariam has had mixed experiences with healthcare. She's been rushed through appointments, spoken over, patronised, never offered an interpreter, and she's often felt like a number and not a person. So slowly, her trust in the system of healthcare has worn away. And I'm telling you this story to make clear how all of these things, her age, her background, her caring role, her income, her education, and where she lives, they don't exist separately. They overlap and they shape how she manages her health and how she experiences the healthcare system and how much trust she places in the people working within the healthcare system. So now, imagine this. A clinical trial for a new diabetes treatment is taking place at her usual clinic. The research team believe Mariam would be a great candidate, so they invite her to take part. They've even thought carefully about the types of people who are most affected by diabetes, and they know that people like Mariam, a woman from a minority ethnic background who's also living on low income, tend to face higher risks and worse outcomes. And they want their trial to include people like her so the evidence is as meaningful as it can be. However, from Mariam's point of view, the invitation doesn't ever feel like it was meant for her. Firstly, the clinic is hard to get to and the journey costs more than she can spare. The information is long and complicated, and no one offers to explain it in a way that feels accessible. The appointments clash with the times that she needs to care for her grandson, and taking part would mean losing income, which just is not an option for her. So on top of all of that, no one has discussed any of this with Mariam. It's clear that the structure of the study is fixed and the power sits with the study team. And while no one says it out loud, Mariam can tell that this trial was not built for people like her, and there's no way that she could ever take part. So this is clearly not about being hard to reach, as Mariam wants good care as much as anyone else. She wants to understand her condition. She wants to help herself feel better, and she would love the opportunity to help other people like her. But her experiences have taught her that when asked to take part in something like this, it's better that she just politely say no. So this is exactly why it matters whose lives we centre when designing research, why it matters how different identities and experiences combine to shape whether someone is even in the room, and why it matters that we pay attention not just to what we're studying, but who we're missing and why. So I hope Mariam's story helps show why intersectionality isn't just a useful concept, it's essential in clinical trials. It helps us to pause and ask, who is this trial really intended for? And also, whose lives have we centered in the design of it? And then also, who might we have unintentionally excluded, not because they weren't interested, but because we never made space for their reality. So Mariam's story isn't rare, but the truth is stories like hers are rarely taken into account when we're designing clinical trials and research. And unless we think carefully about how different aspects of people's lives interact, so how identity, experience, and circumstances overlap, we risk leaving people like Mariam out of the very research that's meant to benefit people just like her. So when we think about people like Mariam, we are shifting our focus towards the realities of those most affected by health conditions, not just those who are easiest to involve. It helps us be more inclusive as we start to design research that recognises the full range of people's lives and actively removes barriers that would otherwise shut them out. It helps us make research more relevant as we're ensuring the evidence we generate reflects the needs and experiences of people who live with overlapping challenges, not just one narrow group. And it helps us run studies that are more effective. Because if we understand what works for people like Mariam, it's more likely to work for many other people too, especially those who are usually left behind. Therefore, taking this holistic approach and thinking about people we want to take part helps us move beyond tick boxed inclusion and towards research that makes a real difference.